say that especially to Cammie. Okay, thanks everybody for coming. Just so you know what my day was like, I had sort of a stressful day yesterday. The surgery is really intense. And 4 hours into the surgery, we had to take a break. I'll show you why we took a break. And Eric goes, I have some really bad news for you. I was like, oh God, what is it? The neuromonitoring SSCPs went out, or there's a huge bleeder? What is it? Because we stepped the table. He goes, no, Terrell Suggs has an Achilles tendon rupture. I just took a second. I was like, but I was really upset later on that day. But during the case, I was like, Eric, don't do that to me again.
You shouldn't do that to you.
Yeah, don't do that to me again. But still, I was upset later on in the day. But it wasn't. It was the timing was poor.
So when Ray signs somewhere else,
what?
You get a contract, don't tell you.
Don't tell me it's really bad news. Yeah, during the operation. Hey, Doug, welcome. Come on in. So I always like illustrative cases because they're relevant, and both these cases were done this week, and they're very fresh in my mind. And many times when you get a real complicated case and you go in great detail, there are many facets to it that you can learn from. So this is the case number one. A 62-year-old woman whose chief complaint was ataxia and her right hand dysfunction. Her hand didn't work well. She had symptoms in June 2011, and she presented in April 2012. So that's quite a time, which is over almost about a year or so. She does have concomitant stenosis from L3 to L5 in her lumbar spine from an MRI. She's a cigarette smoker. She's a right-hand dominant, very high-level nurse. She's a oncology nurse, and they're very high-level people. They take care of patients. She had a workup by a neurologist, which was hey Rob, good morning. She had a workup by neurology, which was negative for a systemic problem like Lyme's disease or some type of vasculitis or multiple sclerosis, things like that. She has a hard time walking to the bathroom at night. She has to look at her feet, and she's constantly stumbling, and her hands don't work well, and her hands are weak. So, Doug, is there anything else that you'd like to know about her exam or history or physical? You don't have to want to know anything, but
her neurologic exam.
Yeah, her neurologic
sensation.
Definite ataxia. I mean, I have everybody walk a heel-toe straight line, like a drunk driving test, and she had a lot of problems with that. She was constantly stumbling. And she said that's not normal for her. And fine.
Long track signs?
No clonus, negative Hoffman's, but hand function was abnormal. She couldn't do fine motor function with her hands, and she says her hands are clumsy. She just feels clumsy. It's more of a symptomatic problem. Her strength is normal, though. Her intrinsic strength is normal.
Should we have evidence of wasting or muscle atrophy?
None that I can see. On exam and on testing, really, but she feels that she's weak. She feels her hands are weak. She feels
a tough time connecting right hand weakness with ataxia without long track signs.
Well, it's intrinsic weakness. So the way that she describes it is intrinsic weakness. So the C8 nerve root goes into the intrinsics of the hand. So it's abduction, adduction of the fingers, and grip strength. So she doesn't have that. But it's a very, the point is it's a very subtle neurological abnormality, and it's hard to really quantitate, Okay, so Adam, what do you see here on these x-rays?
Lateral views of the cervical spine, and I think the view on the left, I'm guessing, is a flexion view, then probably taken at the same time. And you can see anterior listhesis of C3 on C4 that is made a little bit worse with flexion than extension.
This is just so you know, this is just upright film. This is not extension. This is just upright.
Okay.
So C3, C4, spondylolisthesis, some abnormal motion.
Yeah.
And anything else?
Well, and then there's loss of the C4 vertebral body, C5, C6. They do demonstrate sort of classic degenerative change. Or actually, I'm sorry, I missed C7, T1. Boom.
There's
What's that? Quite a bit of anterior listhesis of C7 on T1.
Okay. Okay, good.
you know, the big part about that is you can see how it's pulling the as C7 goes forward because it's attached to its lamina and it's pulling it forward. So the spinal canal, I'd expect between that top posterior corner of T1 and then the lamina of C7, there's going to be a spinal canal stenosis
from here to here.
Yeah.
Okay, good. And just Adam, is it normal for the C5 body to be longer in the AP dimension than at C3? Is that normal?
Yeah. I mean, it is it normal? In a young kid, no. So in a healthy...
How about in a young man like me, 45?
I would guess you already have the C5 inferior end plates already getting longer. And bigger.
Okay.
So, but in a you know, a 20-year-old, no, they're the same. But that's where the degenerative changes start happening. That is the first change that starts happening. Is I think C5 pretty much starts getting that sort of anterior osteophyte, except it's not really an osteophyte. It's kind of an extension of the whole vertebral body.
Okay, and just a couple. Are you? Tell me if are you done? Or you have more?
Yeah.
So just a couple more things I just want to add is from C4 to C7, all of the discs are pretty flat, aren't they?
Yeah.
And I would assume that all these levels are very stiff. I mean, that's what's going on through my mind. So I'm always thinking, I have a problem with my brain. It's always running on and ruminating and thinking and going backwards and making theories, and it's a problem too. But it's how the brain works. So my brain, I'm thinking this is this very stiff segment, and now we have spondylolisthesis above and below, right? So can anyone come up with a theory why that is? Is anyone else?
Got to move somewhere.
She's got to move somewhere, so she's moving there, and that excessive motion at those segments is maybe causing that spondylolisthesis. So what do you see on the, anything to note, Adam, on these this oblique, where you can see the right foramina and the AP?
Yeah, so there's the disease that I would call uncovertebral hypertrophy. The uncovertebral joint on the superior lateral aspect of the vertebral body to the inferior lateral aspect.
Everybody knows what the uncus is? So the uncus is right here where there's a lip. I'll show you on the anatomy later. There's a lip here where it cups the next level, and you can get an osteophyte here. And here's the uncus right here. And you can see what it's right next to, the neuroforamina.
The neuroforamina, yeah.
Yeah.
So anyway, so the neuroforamina are narrowed. And
okay, here it's C5, C6, C6, C7.
You know, I mean, as far as we got lucky that it's a good oblique. The tech did a good job of getting it truly oblique to the foramen, so you're looking down the barrel of the foramen.
And you see a nice view of the pedicle too, right?
Yes.
From here to here.
Yeah, but the space is still there. You know, often you know, C6, 7 is actually. C7,
so this is like a circle.
Yeah. Oval,
so is it normal to have like a woman's figure here?
Yeah. No, the keyhole up. No, I agree. It's
so something's going on, but
it is
not terrible.
And if you look at C7, T1, you can't see it there, and that you just can't tell. Is that the obliquity? Is that the rib in the way?
Not sure.
Actually, I'm looking at this right there. I wonder let's see what. 2, 3, 4, 5. Yeah, there are 7. I was wondering if there are cervical ribs. But no.
And how about these lateral masses? Are they bigger?
I would say that those are facet hypertrophy, probably out that far laterally.
Yeah. Okay. All right.
And it fits that with what we saw in the lateral, that it's at the 3-4 level there, where you've got. I was looking.
I'm sorry, 3-4 what?
Well, you see
3-4 is spondylolisthesis.
3-4 is where the listhesis is, and then you go back to the next one. I've got my pointer here now.
Okay.
It took me that while, but you can see how hypertrophied this is right here. How thin it should be. It should be thin like that with a line, a joint space line right there. But that whole mass of tissue right there is hypertrophied facet, which also it just shows you the stress that's there and the compensatory bone
at 3-4. So the same level where there's spondylolisthesis on the lateral view, on the AP view you see a really big facet. So the facet is getting larger because of the stresses of the spondylolisthesis. How about these are some more views for you?
Yeah, so 4-5 on the left is showing the neuroforaminal stenosis. 5-6 is showing neuroforaminal stenosis and such. And then the last view, which you can see from the head, the patient is trying to be extended.
Right, you see the head's back.
And just as you had said about the 4, 5, 6, 7 level, it doesn't move. There isn't. It hasn't changed.
Okay.
At all there, but she hasn't, or she, I guess it was,
She.
has not reduced the 7-1.
7-1 is not reduced, and 3-4 is not reduced either, is it?
Yeah.
Okay. So anything else you want to add, Adam? Okay, so that was a very nice description. Now back to the clinician, Doug. Anything that Adam said, the foraminal stenosis, is that relevant to you? You take care of the patient, you know the history.
Yeah, C7T1 is where her symptoms of her intrinsic
That stuck in your head, didn't it? Yeah. Because of the intrinsic function and
Right.
And how about all the foramens that Adam described? Was that relevant to you?
Yeah, they look fine except for C7.
But symptomatically,
I thought the facets looked great on the foraminal, to tell you the truth.
but symptomatically they're not bothering her.
Right.
So even though
Yeah.
you have to point all these things out to us, but to us we're just focusing on the chief complaint. So that doesn't mean anything.
And I
to
don't
us.
think her foraminal disease was that bad. I mean, yes, it is narrowed. Yes, there is disease there. But, but when you actually get the CT and you get the nice cross-sectional area, you can see it for how small the nerve is. There's still plenty of room for that nerve to go through there.
But I think can I if you don't mind, can I say something that maybe seem a little critical, but just in general, some people are normal and some people are not, and some people are tight and some people are small, some people are bad. It's really a judgment call. So it's hard because from what you say is a small disc, and then the patient has this horrible radiculopathy, and I don't know why one person has terrible radiculopathy and another one doesn't. But to the patient it's very it's a big problem because so then what happens a lot in the office is the patient's like, why is the radiologist saying it's so small? This is a big problem. So I was like, well, it's anatomically speaking, and when he sees thousands of radiographs on the spectrum, you're not that big, and it's do you see like the dichotomy of perspectives? Yeah. Okay. It's something that we deal with all the time. Okay, so here's just a view of C3, C4, better view. Okay, next is the MRI, Adam.
Well, the interesting thing here, I think, if you look at the amount of anterior listhesis of C7 on T1, it doesn't look as severe here as it did, I think, on the X-rays. And some of that is probably because here the patient is lying supine on the scanner, and it can help sort of reduce it a little bit, as opposed to standing weight bearing that pushes it forward.
And also they get in the scanner, it's like an hour ordeal, so they're relaxed, and the thing can kind of stretch over an hour too.
Yeah.
Okay.
But beginning at 5-6, the spinal canal gets narrowed. There's a little bit of what I say bone disc complex extending posteriorly into the spinal canal.
Right here.
At 6-7, and then at 7-1. There's the malalignment. Normally at C7, T1, or actually it's behind C7, the spinal canal does open up. So you can see at 4-5, the canal looks just as narrowed as it does at 7-1. But that's on a background of at 7-1, it's supposed to be a lot wider. There's supposed to be a lot more space there. So the degree of spinal canal stenosis at 7-1 is more than at 5-6 because of what the baseline was probably before the listhesis.
What's this black stuff, Adam? Right there.
Yeah, don't really know. I would say that it's thickened ligament, perhaps, but I don't really know.
Or so just give
Could be bone,
guess.
cortex, and ligament.
Okay, in my mind, this stuff is either ligamentum flavum or facet capsular tissue, because the facet can hypertrophy incredibly and cause synovitis and can compress into the spinal cord. So that's in my mind. That's what that is when I look at it. Okay, so does that add anything or not really? Just
not
focus.
really. And I mean, the thing you can say is it isn't a tight impingement going on there. The thing you can also say is there's no chordedema there.
No cord. Signal change.
Right. There's no signal change. No atrophy. I mean, it sounds like that's got to be where her problems are coming from, but it can be a lot worse.
Okay. So this, I'm showing you an MRI at you can 3-4. So what do you think here?
The spinal cord is nice and round in the center. There's CSF 365 or 360 degrees around it, and it's wide open.
And at least several millimeters of CSF. Now going back to what's normal, because I agonize over this all the time because I have to deal with people, and I feel like, am I being too aggressive as a surgeon doing surgeries on people who are normal, you know, and what is normal? And then, so this is my rule of thumb, is I use the normal, what I think are normal levels as that person's baseline. So this is what this patient's spinal canal should look like, I feel. This is C3, C4, and maybe the whole canal should look similar to this. Is that fair?
Yeah, I think maybe the cord shape might get different.
Somewhat.
Yeah, but
like that's kind of like an internal control.
Yeah.
Okay, that's kind of what I'm talking. I'm not sure what's right. That's why I'm asking you, because I learned from you too. But so this is C3, C4. The spinal canal looks good, but yet there's spondylolisthesis at that level too. We know. Mm-hmm. So how about here at C4, C5? Adam?
Well, now we're at the level of the foramen. You can see the openings on the side, and there's the what you.
So from here to here.
Yeah, but then there's that dark signal right there.
Mm-hmm.
It's narrow. So the left neural foramen is narrowed.
C4, C5.
Yep.
How about at T1?
T1, you know, again, you've got circumferential CSF. We can see the little nerves in the CSF. Yep. Mm-hmm. Dorsal and ventral nerves coming off.
Okay.
And then there's no CSF. Mm-hmm. So you can see on the side that is 6, 7, I think.
6, 7.
6, 7. So there's no CSF around there. The foramina are pretty good. Maybe a little bit of narrowing there on the left from the uncovertebral hypertrophy, but the spinal canal is stenotic. Again, looking at the shape of the cord, though, the shape of the cord isn't that bad.
Looks pretty similar to what I said is internal control.
Yeah.
A little different.
A little deformed posterior left.
Yeah. How about 6, 7?
And now at 6, 7, again, there's no CSF. You can't even really separate out the cord from the surrounding tissue. So again, a cord impingement, spinal canal stenosis. So if you compare that to with Spiro's, let's call it Spiro's baseline, what do you think? It's spinal cord impingement.
So I'm saying if you want to hedge as a radiologist, you can always say, look, compared to other levels, this level has much, decreased spinal canal diameter. And that way you're still saying the truth. You're not making a judgment call, severe. What do you think? I'm just throwing it out there as an idea.
I see.
You don't buy it. Okay, you don't have to buy it. How about C7T1?
C7T1, where you can see the arrows there on for the facet arthropathy indenting in, causing some canal stenosis abutting up to the cord. But there is still some CSF in there, and the foramina look pretty good.
Okay, so I have a question for you, Adam, is if you had to describe this to your children, they're doing geometry, what shape would it be?
An oval.
Okay, but this is oval? Look at this. Don't you think that's kind of round? Like a circle?
Okay.
If you're playing a sport, look at this circle, Nate. If you're playing a sport here, Nate, with that structure, would the sport be basketball or football?
I'd say that's more of football than basketball.
All right, you guys are. You guys are.
Triangle.
What, triangle? You say it's a triangle? All right, nobody agrees with me today. All right.
It's a circle. Fine, it's a circle.
All right, it's okay. No.
Scaling triangle.
It's a water balloon.
All right, you don't have to agree. I don't want you guys. You guys, huh?
Next.
Everyone has something different. All right, I felt that was kind of roundish because the facets were compressing enlarged going into the spinal canal, compressing a spinal cord at C7T1. But that's what I think. Because look at here, it looks like more like a football at T1. That's just below that level. And here it's kind of roundish. So I think her spinal cord's compressed there. Anyway, it's just. So the other thing is in spine, there is some literature about the shape of the spinal cord. And it's mostly Japanese literature because they have a very high incidence of cervical stenosis. And if the ratio from anterior to posterior, to medial to lateral, is less than 0.4, so it's flattened like a pancake, if it's a totally asymptomatic volunteer, those patients develop myelopathic symptoms within a year. So the shape of the spinal cord does have significance clinically as far as giving you a prognosis. Okay. So now what do we do? What are your thoughts? And Doug, I know you're not a spine surgeon, but you are an intellectual person, so you just put on your spine hat and just fantasize you're a spine surgeon. What would you do? Let's say problems list. What's her main problem?
I think her main problem is her right upper extremity dysfunction. I
And
think it's related to C7T1. And I think that the problem is that she's got an abnormal segment next to C7T1.
at C6-7. Remember, Adam said C6, C7 is tight too.
C4, 5, 6, 7. So,
And all of these are arthritic.
you're going to try to decompress her.
And then this is spondylolisthesis too. So I'm sorry. So this level is definitely her main problem, because that's probably giving her intrinsic weakness and probably maybe her ataxia. And then C6, C7 is definitely stenotic, right? And C5, C6, C4, C5 aren't normal either, are they? Are they?
Our whole
And C3, C4 has spondylolisthesis.
there's nothing normal about her, but
There's nothing normal about the cervical spine, is there?
including the surgeons. But you know, I don't think that the solution to her would be a very extensive. I think she's got disease isolated to 1 or 2 segments.
So just do a C6 to a T1 ACDF? That would solve all of her problems?
I'm not sure about an ACDF.
Okay.
Because I'm an old guy, but I think that she needs an element of decompression, and it looked like on the sagittal that she had posterior impingement from her ligamentum, and
She had that.
and so I think she needs both a decompression and a stabilization procedure.
So posterior decompression stabilization, maybe C7 to T1?
Yep.
That would be a limited approach?
Yep.
I think that...
6, 7.
I think that's reasonable. I think it's a very reasonable approach. This is some normal images, what I think are kind of normal-ish. You see how there should be plenty of room for the spinal cord, the spinal fluid all about it. And here's our uncus. That when this, it's this part right here, and it goes up like that. It's kind of like a, see, can you see how that kind of cups itself, the uncus? And it's right next to the foramen. Okay, everybody, let's go to the videotape.
Can I ask you a question about the,
Yeah, absolutely.
the stumbling? Why is she stumbling? I keep having to look at her feet when she first got there.
I think it's from the spinal cord. I may be wrong, but I think it's from the, I don't see what else it could. She had a neurological workup. Everything was negative. Brain MRI is normal. Thoracic MRI is normal. Lumbar MRI had lumbar stenosis.
Nerve conduction studies?
She did. She did. Nerve conduction study was totally normal.
So if you use, you're going to have to get those special glasses where she can look down, because her neck is going to be so stiff, she's not going to be able to look down.
She will lose a lot of flexion, actually. Yeah.
But is there compression on the cord in the cervical area that's causing the stumbling? Is that what you're saying?
I think so, but I'm not sure. It's not a classic case. So she's like a gray area in medicine that we get all the time. We don't know what to do sometimes. We have to do what we think is right and make our best guess. So I'm pretty sure that's what it is. I wouldn't recommend the surgery for it if I didn't think so. Okay, so let's go to the, hold on. Let's go to the videotape. So just so you know, I decided to do a posterior reconstruction, the whole ball of wax, C3 to T2. So that's what you're going to look at. Whether I should have done that or not, we can discuss it.
Well, but she had a spondylosis C3, right?
I felt we had to fix. I talked to her. She's a nurse. I felt we had to fix everything. You know, I gave her limited options, but after discussing it, she's a nurse, very intelligent woman. She was definitely part of the decision-making process. She wanted the whole thing fixed. So the implants I always put the implants in first, because the spinal canal is not exposed. That way, I think it's safer, because there's a lot of manipulation, and there's always a chance that the implants could hit the spinal cord. So I just put them in first. Now I'm doing the laminectomy, and you do it in troughs. I'm exposing the spinal canal here above and below. So this is the lamina. Like the head's over here, and the buttocks is over here. I've already done the lamina foramina.
Can you do that part again for me, quick, please?
Yeah,
Which way the head is?
Sure.
Make this really. I don't know if Alan knows what you're looking at much, but
No, I don't.
you know, if
Okay,
you're looking
okay,
at
I'm
the
sorry.
back of the spine, and you're
Yeah.
looking at pedicle screws
Yeah.
and a bar connecting the pedicle
Yeah.
screws, and the
So the implants are already in place laterally, and this is over here is to the right, over here is to the left, and the buttocks is over here, and the head is over here, and we're looking at the posterior cervical lamina, and it's kind of like this. It's kind of like a rectangle. This level has gel foam on it. I've already done the C7T1 laminoforaminotomy decompression, which was remember, it was stenotic at C7T1. Specifically, interestingly, where she had the grip strength weakness, she had a large, loose facet osteophyte compressing her spinal cord, which took me about 30 minutes to peel off her spinal cord, which did not show up on any imaging. Why? I think C7, this is Spiro's theory, I don't know, but I think C7T1 is an especially very difficult level to image because of the shoulders, and you don't get very clear images because of that. So, and it didn't show up on anything, but clinically that's what it was, and sure enough, in the on the surgery, that's what I found. So now I'm just doing a laminectomy at C5, C6, and you do this by, so this is the lamina. You can't really just take the lamina off because it's severely compressed, so you kind of cut all around it and lift it off in one piece in a lobster tail technique. Have you guys ever seen this before? So I'll show you. It's pretty good video. You cut below and then you cut above the ligamen flavum. So you detach the ligamen flavum above and below, and then you make two troughs on either side of the lamina.
Is that what you're doing right now? Cut through the ligament?
This is ligament flavum. Yeah. See how I'm peeling it off? So the attachment is inferior, and the attachment superiorly is kind of like in the middle of the lamina, so it's better to do it inferiorly. These are all little things that you learn as a surgeon to take care of things.
How sharp is that little thing on the left of the screen? Is that
like a knife? That thing's a 1 millimeter. It's a Codman curette, microcurette. Codmans have the best microcurettes. I don't have any conflict of interest with Codman, but I use them. They're fantastic. And that's a 1 millimeter backwards curette. They have backwards and forwards curette, 1 millimeter. So it looks, you can kind of, that burr that you're seeing there, the high-speed burr, is a AMA. What size is it, Cami? It's like 3 millimeters. 3 millimeter, right? I think 3.3. That's a 3 millimeter microcurette. So not microcurette, a burr. So you can kind of, that gives you an idea of how big everything is. So we're thinning down the lamina with the burr under the microscope and removing ligament flavum to expose the cord above and below. Hold on.
Now, what I think, you don't try to reduce that listhesis.
I don't. No, not in this case. I think it's too dangerous. So, and that was a kerosene punch here. That once you get the lamina real thin, you can pull it away with that kerosene punch. And the kerosene punch, is 1 millimeter. So in the cervical spine, I almost always use a 1 millimeter kerosene punch. Okay, so that kind of gives you an idea. I'm disconnecting it there, and then let me show you. Next is show you the trough. Sorry, guys. The trough is 3. I think it's like 10 minutes of video is a half gigabyte if you guys are interested. So now I'm going to make the trough on either side. This is the center and these are right and left, and you make a trough up and down the lamina. So see how I'm drilling a trough on either side of the lamina? So I'm just going thin, Eric's sucking for me. I keep going thin, and I can see and feel when I'm through. And there's above and below, there's ligament flavum that keeps you safe from the dura, so you're not drilling right on the dura because you don't want to do that because then you get a spinal fluid leak. Although the AMA bit is not that sharp, and it usually does not cause a drill tear, but it can happen. I've had it. It's happened to me before. So I'm feeling and I'm getting down to I'm all the way through. Good morning, Eric. So I can't say anything bad about Eric anymore because he's in the room. So that's Eric sucking, and I'm disconnecting, and you can see I'm pretty much through there, and I'm finishing it with a kerosene punch. So I'm all the way through with a kerosene punch. So it kind of gives you an idea. And now that trough is done. See that? See I'm all the way through the whole way, and it's soft. And see those little bleeding vessels? There's a leash of epidural venous vessels at this area laterally. I don't know why. It's like, I guess God wanted to make spine surgery a little difficult for us, but He put them there. So we always get them and we pack them off, and it's sometimes they're very big, sometimes they're not so big. So you see we're kind of done. And this is Flow Seal that I'm inserting, which is a Baxter product, and it's an extremely effective anticoagulant. Costs about $500 for 10 cc's. The hospital used to give us a lot of flack about it, but they don't anymore because we say we need it. So, you guys want to see more trough, or are you done with trough?
I want to see take away the.
Okay, lobster tail. Okay, Adam hasn't eaten breakfast. He's hungry. He wants to do lobster tail. Okay, here's the lobster tail. So we lift, so it's been disconnected, but it's still attached to the ligament flavum, and this is the spinal cord here, and now it's peeling off like a lobster tail. See that? And we're pulling it off indirectly, and that's the safest way to do it. But there's always these attachments left from the scar, and if something's been scarred for a really long time, like for years, it develops scarring and ligamentous attachments to the dura. So now we're pulling off the lamina off the spinal cord and nerve roots. You see all these little attachments? So we have to do it really slowly and gently, and the whole time we're peeling off these epidural vessels and attachments to the dura itself. So we don't want to, traumatize the spinal cord by manipulating it violently, and also we don't want these things to bleed. So we're doing it very slowly. This kind of gives you an idea of what it's like. See that little vein right there? It'll be done in a second. See all the attachments, and this is the spinal cord itself, with a dura, and inside the dura spinal cord. So looks much better, doesn't it? Looks like it needed it. And the other thing is, you can see it's really pulsating now, which is from the heart. So you have your own little. You can the heart rate by just looking at the dura. So there's still some ligamentum flavum here, and here's a C7 lamina. So this is she had a C5, C6 laminectomy, and then I feel the sides because frequently there's some.
Yeah, how about the sharpness of that bone right there that he's sucking on the bottom?
Yeah, no, I was worried about that. Okay, that's funny you said that, right? See how it's sticking in there?
Yeah.
Can't get anything past Adam. So see, I'm taking that away. I saw that too right away. I was like, let me get that sharpness away. So that's a 1 millimeter curette, just to do some finishing touches to make sure there's no residual spinal cord compression, because we don't want residual compression and then the patient still has symptoms.
So you only did the laminectomy at C5, C6?
Yeah, C5, C6, but I also did a C71 for ammonotomy. Okay. So the problem with going out lateral is these big vessels again. And you don't see the vessels on the MRI. They're not too small, I guess, to be seen. Sometimes we see them.
Right. Depends on the flow.
Yeah. So, but they're also, it bleeds a lot, so it's kind of a difficult place to decompress. Okay, I think that's good enough.
And then how far do you go before you worry about instability?
We fused it, remember?
Well, exactly. Meaning though that screw doesn't have purchase, because if you get so close to
that's always an issue. Yesterday, Eric goes, "Be careful," because he thought I was burning too much while I was decorticating for the fusion, and I was right next to the screw. It's always an issue. Okay, so just one.
Yeah, but that's not what screw fixation is. Screw fixation is
lateral mass. Yeah. So I just looked up because I read the radiology reports, and sometimes, I'm not saying about you, Adam, but other radiologists, it was like this is not normal. So this is from the European Journal of European Spine from February 2012, very recent, and they did MRIs on 1,200 healthy volunteers, and there are at least 100 men and 100 women in each decade of life. So there's a lot of people, and they're all asymptomatic, and they found that the sagittal diameter of the spinal canal was 11 millimeters. And the cross-sectional area of the spinal cord was 78 millimeters in general, and slightly less at the level of the disc space at C5, C6. And the area occupied by the spinal cord in the dural tube was 58%, around 58%. So, and then what's interesting is in these asymptomatic volunteers, 5% had spinal cord compression, and then 2.3% had T2 signal change. It's pretty amazing, right? All these people are asymptomatic. So there are a lot of people, I guess, live with cervical stenosis and have no symptoms whatsoever. But maybe we're just catching them just before their symptoms, who knows? And so this kind of shows you the troughs that we do on either side, and then we lift it up. And see how that kind of looks like a lobster tail? So it kind of gives you an idea. So this is the surgery that I did, the laminectomy at C5, C6. At C7T1, I did a laminoforaminotomy decompression. I left the arch of C7, T1, so I could put bone graft here to get it to fuse. I think it gives it a little more strength. And I put 4 screws below the C7, T1 spondylolisthesis, because it's an abnormal level with motion. So I feel I need a very strong a connection there, and 4 screws above. And these are just my notes in my book I keep. I had to switch out the left T2 screw because it was initially too lateral. And at left C7T1 facet, there was a huge osteophyte. Actually, that was opposite of symptoms. So I don't know why that was. And here's a lateral view. So her entire cervical spine was almost entire cervical spine, but half of your motion occurs at the occiput C1, C2 segment. So these people usually don't feel like they're stiff, and these people are stiff anyway through these segments, so they usually don't complain of stiffness. So what do you think, Doug? Any comments? Or anybody have any comments?
I think it looks great. I think you've restored her listhesis at 3-4, and it's tough. It's a typical orthopedic surgery thing where you put a lot of hardware and you can't see anything else, so it's tough to see C7T1. And I think it's true. You know, when I was a resident, we used to do a lot of spine surgery. It was usually traumatic, and it was usually high fractures. And that was a deal where I think 50% of your flexion is C1, C2, and 50% of your rotation is occiput 1. So those are the high levels of motion, and those are also the high levels of injury. So when you, and you know, I guess going forward now, the thing is I think she had a high, you know, so the next question is when she gets into an accident, a car accident, or when she falls or something, you know, do you think she's at risk now that the level right where the hardware ends or the fusion ends?
At C2, C3?
Yeah, is you know, high.
It is.
Level of injury now, and
it is at risk.
You know, she used to have 7 segments where she might fracture.
She can be paralyzed from. She can be paralyzed from T2, T3 from an injury.
Right.
I've seen that happen in one of my patients.
Right.
So definitely at risk.
And she's fairly young.
62. Depends on how old.
Is she still working?
Oh yeah, she's very very active.
As a nurse.
As a nurse.
So she have a lot of lifting and straining.
No, but she's very high. She's a oncology nurse. She's a very high level functioning person. I mean, those people they function at the level as a physician. Yeah. Okay, any questions about anything? I thought that was kind of an interesting. Okay, here's another. Here's the next case. Same week, similar problem. 75-year-old man, and Don Juan's going to be our clinical doctor today. 75-year-old man with bilateral hand paresthesias and quadriparesis. He's a great guy, actually. I've known him for a very long time, like 7 years. Actually, more than that, 8 years. And he had an onset in December where he's had buzzing, weakness, pain in his shoulders, deltoid area, and his hands don't work well. He's had a long history of a C8 palsy on the left and bilateral hand intrinsic atrophy that I've been just watching. I know he has cervical stenosis. He's recently had a left carpal tunnel release, and it didn't help his symptoms. General surgeon, orthopedic surgeon did that. I performed 7 years ago a C3, C4 ACDF because he had a very large disc herniation above, and he had spondylolisthesis there above a very stiff kyphotic segment. Same as the last person, isn't it? Remember, C3, C4 had the spondylolisthesis, but he also had a very large disc herniation. And 7 years ago, I was like, let me just do this, like Doug, the same approach Doug said. Let me just do the worst level, see what happens, and he did great. But now things aren't working out well. He's walking. His wife says like a penguin, a wide-based gait, short strides, shuffling, and he falls. And his hands are extremely weak, and to the point now where he can't grip. He's got no hand function. He's also has a kyphotic posture where if you ask him to put his heels and his buttocks against the wall, the closest his head can get to the wall is 3 fingers. This is kind of like a measure of spine kyphosis. So any other questions that you want to know, Don Juan? So 75-year-old man with difficulty walking, quadriparesis, bilateral hand dysfunction.
So the muscle stress for 4 extremities, how much?
Everything's like 4 out of 5.
How about
3 out of 5, 4 out of 5.
Tendon reflex.
He has clonus in both feet.
Okay.
but otherwise intact. Hoffman's negative.
Negative.
Both hands have intrinsic weakness. Left greater than right. Anything else you want to know? Okay, Adam, what do you see here on the images?
We can see the anterior fusion at 3-4 with a prosthetic disc spacer that's still kind of bright right in there posterior to the metal.
If you don't mind interrupting, that's a cortical cancellous allograft,
Okay,
and it's 7 years old.
all right. Well, it hasn't been incorporated very well, I think, for 7 years old. But the big problem, I think, is more at 4-5 and 5-6 with anterior listhesis of 4 on L5. And although 5 is not really anterior listhesis on C6, if you look at the posterior elements back there and look at that huge space that between the
They're spreading apart, aren't they?
Yeah, they're spreading. And I'm looking actually right where your thing is there. That gap right there is abnormal. So
Gets any more, it'll be a perched facet almost, doesn't it? But it's not a trauma.
So, and then it looks like there's probably fusion of posterior elements at 2-3. Very hypertrophy.
Interesting, right?
Yeah, that you don't see
Let me tell you a weird thing. In orthopedics, when you have kyphotic deformities that are chronic, they fuse posteriorly. So I've seen this in kids with a huge kyphotic deformity, and it's fused, but it keeps getting worse. So I think they probably develop stress fractures, and they also stretch. So the body somehow wants to stop this process. Maybe not. I have no idea why. But I've done many cases where it's fused, and yet you have this huge deformity. So that's a very interesting point that you bring up. Okay, so what about the obliques, Adam?
And on the obliques, we were talking about the nice round foramina, and right there you can see one that's wide open, but then there's nothing there. There's nothing there. And, there's 3 levels, I think, here.
Now you want to blame the text, or is it from the anatomy?
Well, because you can see this one up here, and because you can see that one, that means that the obliquity is okay.
The sets look perfect. I never see an X-ray look that good.
That's right.
With the facets.
And now on this side,
you can see them right there. That's great.
Yeah, and here's the widening right there. You can see that widening.
This facet looks like it's almost about to dislocate off that one, doesn't it?
Yeah, it's so high up, and there's so much angulation there, flexion there.
Okay. So definitely kyphotic. How about the CAT scan, Adam?
That's showing the anterior listhesis of 4 on 5. The disc disease at 5-6, which is bone on bone with sclerosis, bony hypertrophy extended to the spinal canal. If we looked at the axials or went out, you'd probably see some the uncovertebral hypertrophy contributing to that neuroforaminal disease.
How about I always think about, I'm like egocentric. Yeah, did my surgery work? Yeah. I'm always thinking about myself. So it did work, didn't it?
It did work.
How about, okay, Adam, back to your theory that he's fused posteriorly. Does that change your mind at all?
No,
right here?
there's no joint space there.
Looks pretty fused, doesn't it?
Yeah.
Okay. So interesting, right? Very interesting case. Okay, let's keep going.
Allograft?
Yeah, cortical cancellous allograft. Okay, here's the MRI, Adam.
These are lateral T2s because the CSF is white and bright. And
here's the CSF guys right here.
The canal is pretty good until you get to posterior to 5. And at 5, the spinal canal starts to get narrow.
Right there,
C5, C6.
C5, C6, right?
You have probably a cord impingement, even 6, 7, probably cord impingement, 7, 1. There again, there was some curvature to the spine, some scoliosis. So I'd have to look all the way through, every sagittal image.
And you say that you don't tell everybody. Here's the posterior spinous process, and yet here's the facet.
Yeah.
So something's rotated off, or he's not in the scanner, right?
Right. Right.
Okay, so C5, C6, C6, C7, C7, T1, and T1, T2.
Yeah, but I'm guessing 1, 2 is probably not going to be as bad. Maybe if we looked at the axial image at the level, or
we'll take a look at it.
But, yeah.
How about this, Adam? What is that? Is that color different?
Yeah, that is some gliosis or myelomalacia, sort of terms to use where it's abnormal edema within the cord. Again, this was a fused level, so probably when you talked about that he had a big disc there.
He did.
And so this is sequelae probably from spinal cord impingement from when that big disc was there.
Look at the fusion on the MRI. It's a solid, continuous bone fusion. It's kind of interesting. Anything different here?
You can see how 4 and 5 are fused there, the vertebral bodies.
So 4, 5 onto an autofusion.
Yeah.
Interesting, right? What is this? I don't know. It's like a dark image. Is this a stir image? Or?
Yeah, this is fat suppressed. There's always it's a T2 again because CSF is bright, but fat should be bright unless you do something to suppress it. And the thing we do called inversion recovery or fat suppression, or make the fat so the vertebral bodies are dark, just like the fat is dark, and there's fat in the marrow of the vertebral body. So this is fat suppressed. What this is really good for is seeing edema within soft tissues, whether it be marrow edema.
Fat suppression is really good for edema within soft tissues?
Yeah.
Okay.
But again, what we can see, you can see how bright that lesion is right there in the cord.
The myelomalacia lesion.
Yeah.
Yeah. Okay.
What are you looking at posteriorly at C1, C2?
This thing?
Yeah.
Hypertrophy of ligamentum flavum, I would guess.
Yeah, I would think so too.
Seems pretty dramatic.
Yeah, it is, isn't it? You don't see it. You see it right there too. You want to fix that too? Just noted it. Okay. So here is 3, 4. So let's see. It's 4, 5.
4, 5. The right, that you can see the bone extending posteriorly into the spinal canal. It's more severe on the right than the left. Probably pretty much narrowing that right.
Now, wait a minute. I thought you said C4, C5 is fused. How can you have spinal cord stenosis with a fusion? Shouldn't it be like, I don't know.
No,
What
there's
happened?
hypertrophied bone. It's malaligned.
Okay, so it got hypertrophy, but then it fused. Once it fused, it shouldn't change. But so it must have fused after he was compressed. But it's kind of interesting.
The fusion can be hypertrophic bone that extends posterior. It doesn't have to be just where the natural bone is.
How about T1, T2?
T1, T2, there's spinal cord impingement. We lose our CSF surrounding the cord. The posterior elements, you can see that dark signal posteriorly, how that's sort of thickened ligamentum flavum and scar tissue. And so it's stenotic.
How about T2?
T2 is a little bit better. It's not normal, but it's better.
So I kind of use it as my internal control. That's what the spinal canal should look like, and that's what it looks like T1, T2. This is 6. What level is this? 5, 6, 7, 7, 1.
Yeah, and it's stenotic. No CSF. Posterior elements hypertrophied and ligamentum thickening.
Now this, I didn't think much of this thing, but this thing, intraop. Eric, how would you describe that left C7T1 segment intraop?
Soft osteophyte. It had some hard bars, but it was kind of mushy. Not mushy, but it was like kind of newly forming osteophyte.
Was it just like barely hit? It was deforming the cord, right?
Yeah.
Pretty.
About 3 4 millimeters maybe.
Yeah, I mean it was a lot. It was incredible actually. And how about at C5, C6, Adam? What do you think of the cord?
It's deformed. It doesn't have its round shape or oval shape. It's a triangle. And,
This looks like a sharp. Look at how sharp that is.
Disease a little bit more severe on the left than right. Not much, very little CSF surrounding the cord. So spinal canal stenosis impingement. Same there.
6, 7.
Again, more severe on the left. The foramen. You can see some foramen on the right, but on the patient's left, there's the foramens included.
Very tight, man. Okay, just so you know, the C8 nerve root, as a review, exits C7T1 segment and gives you finger flexion and sensation to the lateral border of your hand. So it's commonly confused with cubital tunnel syndrome because the ulnar medial, I'm sorry, medial hand, ulnar hand. So now what, Don Juan? What do we do with this guy? Let's go over the problems.
Seems like it's a combination of the foraminal stenosis and also
And the spinal cord is compressed at many levels. It's compressed at C5, C6, Adam told us, C6, C7, Adam told us, C7, T1, Adam told us, T1, T2, Adam told us. So many, many levels, plus he's deformed. It's kyphotic deformity. And, something you think we should watch?
probably just decompression this time.
Yeah, he's telling us he doesn't want to be watched anymore. He can't function now. He's losing function, so we have to do something. So definitely a decompression. Now, just give me a guess. You think the decompression will be easy from the front or hard? He's a big dude too.
I think it'll be easier from the back, right?
Yeah, a lot easier on the back. Yeah, anterior will be a really deep hole, and it's kyphotic. It's extremely difficult surgery to do a corpectomy. But posteriorly, it was hard, but nothing like how it would have been in an anterior approach. So posterior laminectomy. But then after the laminectomy, Aren't you afraid a little bit it may deform worse?
Yeah, that's possible.
Yeah, so normally the cervical spine has lordosis and it's upright, so I think if you're going to do a posterior approach, you have to fuse it as well. So he had a posterior approach, and we did laminectomies, partial C4, full laminectomies, C5, C6. At CC71, he had this large osteophyte compressing the spinal cord, and we had to peel that off the spinal cord and lift it away. And at T1, T2, I just did a laminopharaminotomy, opened up but left the arch of T1 intact, and instrumented him from C4 to T2. You can see the AP view. And we have the O arm now. Do you read the O arm? Okay. The images were in the computer though, so you guys you put them on the computer, but you don't read them.
No, I mean, I haven't been reading them here for 4 months now. But,
okay. I don't know if they're ready out to read. Yeah, and
they're very. I mean, I can see the utility they provide you in the OR.
Intra-op.
To see where you are and what you're doing. But as far as for us, the quality that we're used to putting our name on the report.
It's extremely poor quality images, yeah. So this gives you an idea of what the quality is. This is probably the best image we got, and it's very operator dependent. But you can see here pretty clearly. Here's the spinal canal, and here's the pedicle of T1. And I can tell you, this patient, you could not get an intra-op fluoro with the C-arm. Impossible. We couldn't see right here. Couldn't see anything. So we didn't even use it. We just used landmarks and alignment and palpation to put all of our implants in, and then we checked it with the O-arm. And the O-arm worked pretty well in this case. Gave us confidence that everything was in a good position. So we can thank Medtronic for that.
O-arm is a portable CT scanner that you just wheel into the operating room. You put the patients on the table, you just put it around, you guys circle. You can get a CT intraoperatively in 14 seconds, and they'll reformat it for you. I expect you're going to be using it in the unit next year, because we're probably going to get an MRI machine that you can use in the OR someday. But it's pretty high tech,
Yeah, the O-arms. I don't know if we can pull up an image quickly, but it's quite incredible. Intraoperative. It's an intraoperative CT. We do search images.
I think they just got approval to do soft tissue.
O-arm Medtronic.
Release for soft.
How much? So here's the O-arm.
It's like $80,000.
How much is it, Nate?
It's more than that. Yeah,
It's
about
500,000.
So the patient sits in here.
It's a lease,
about
though.
850,000.
Yeah.
850,000.
It's a lease.
We're releasing it.
You have to use it a certain amount of. It's like
Yeah.
It's $1 million unless you use it 3 times a week, and then it's free.
It's a real. The deals these guys make. It's like a Byzantine bazaar. It's like, I'll give you this if you give my mother this and that.
Right. I was talking to a urologist the other day, and Boston Scientific makes these ureteral stents, and apparently they make so much money on these stents that what they do is they give the urologist all the scopes, everything, so they can do the procedure if they just promise to use the stents, and it's like, I'm like, wow.
Yeah, it's fun, but it's so the patient sits in here, and let me tell you, just barely fits. I mean, it's just we. How much clearance do we have, Eric?
Maybe yours, but I've used these on calcaneus fractures a couple of times.
On a regular OR table.
Yeah, where you're coming in from the other end and just put their foot through it or something.
Yeah.
It is like it gives you incredible information.
Yeah, especially if it's an obese patient,
it's great.
You get a great image.
Right, it's great for extremities, but for some, for some spine stuff, it's much more difficult.
In the spine table, it
so
just
much,
barely fits. Yeah.
Interference
and it takes about 30 minutes.
For what?
To do it.
Come on.
Getting it in.
30 minutes. Right, Eric?
Yeah. Okay. 20.
Huh?
20. It's a big, heavy thing, and it does it. They don't push it. It moves. It's like and they put it in, and then once you get it set up, so for me it's not so bad because I have it in the room, and they just sort of slide it into the foot of the table, and then it's called an O-arm because that whole thing comes around.
It becomes an O. It closes down.
And and you can do fluoro, so you can just get some X-rays with it, which are really incredible. And then they'll do the whole thing to do a CT is like 14 seconds, and they'll reformat it right there for you in the room. It's like, wow.
So here's a T1, so that's T2, here's T1. Screws are perfect like they always are. And here's the lateral mass screw. Here's the lateral mass. You can see it's right there. You want to miss the vertebral artery, which is right here. That's it. This is me at the meteor crater with the gang. Thanks everybody for coming. Any questions at all? All right, great. Thank you for coming.
Thank you.
See you next month.
Thank you.